Welcome to this session on the acid-base balance physiology and interpretation of acid-base balance defects on the ABG analysis. So this is session 2 of the ABG analysis. In the first part of the ABG analysis, we discussed interpretation of ABG and the discussed about gas exchange defect and types of respiratory failure. Now, in this second part, we want to discuss the diagnosis of acid-base balance defects on the ABG. We discussed in the first page of respiratory medicine that respiratory medicine also plays a minor role in acid-base balance. So, to understand that role, we want to review the acid-base balance physiology first. So, to understand that, we must begin with the term that the human body is always considered pro-acidic. The human body is always considered to be pro-acidic. That means it has got a tendency to develop acidosis. So why do we say that? Because every living cell in the human body needs energy. Every living cell in the human body needs energy, and energy, the currency, is in the form of ATP molecule. And we have learnt in biochemical pathways like Krebs cycle, anaerobic glycolysis, that during the ATP synthesis, we have learnt that during the ATP's production in the cell, acid is generated as a byproduct. The acid is generated in the cells as a byproduct, and that is why we can say that as long as we are living, there is a continuous production of acid because of the biochemical reactions which produce ATP molecule in the cell. And that is why there is a tendency of the body to tend towards acidotic. But in spite of this normal physiology, when I look at the normal blood pH, what do I find? That the normal blood pH is 7.35 to 7.45. That means the normal blood pH is actually slightly alkaline. Forget about acidic, it is actually slightly alkaline. So, if in spite of the acid being continuously generated in the living cell, if the body has to maintain an alkaline pH, needless to say, the acid that is generated in the cell needs to be excreted out of the body. To do this job, we have got the three mechanisms of acid-base balance. We have got the three mechanisms of acid-base balance which regulates the blood pH. We have got the three mechanisms acting in the body and regulating the pH of the blood. So which are these three mechanisms? Number one mechanism is called as buffering. Number one mechanism is called as buffering, along with number two mechanism, which is the respiratory mechanism of acid-base balance, and number three is the most potent mechanism of acid-base balance, that is renal mechanism of acid-base balance. So we can say that to maintain the acid-base balance in the body, there is buffering, there is the role of respiratory system, and the most potent role is played by the renal system, is played by the kidneys or the renal system. But we want to know a little bit more about this physiology. The buffering occurs at the tissue level itself. The buffering occurs at the tissue level itself. As soon as the acid is generated in the cell, it is going to be buffered with a buffer. The buffers in the body can be subclassified into two based on their site. The extracellular buffers which are present in the plasma and the intracellular buffers which are present in the cell. Needless to say, the most important buffer in the body, the most important buffer in the body, single most important, is the bicarbonate. All of us know the bicarbonate is present predominantly in the plasma. That is why when it is asked what is the most important extracellular buffer in the body, the correct answer should be bicarbonate. But the moment they say which is most important intracellular buffer, the answer changes to phosphate. This phosphate is obviously has to be derived from the bones when it is needed. Bicarbonate is already present in the plasma, but in conditions where the bicarbonate is depleted, the body will need the services of phosphate to act as a buffer, and when the phosphate will have to come out of the bone into the blood to act as the buffer. So let us look at the story. The acid which is generated normally during ATP synthesis is first buffered. After buffering, it is transported to the two organs which are going to excrete this acid out of the body. Transported to the two organs which excrete the acid out of the body. Among that, the respiratory system plays only a minor role because the lungs excrete the acid in the form of CO2, excrete the acid in the form of carbon dioxide. That is why I told you that carbon dioxide can be considered as a gas also as far as the respiration is concerned. It can be considered as a form of acid also when you look at it from acid-base perspective. So the primary defect of the CO2 are called as the respiratory defect. The primary defect of the carbon dioxide are called as the respiratory defects, which we also studied in the previous session under the heading the hypoventilation and hyperventilation. But among the acid-base balance physiology, the most potent organ are the kidneys. What do the kidneys do? The kidneys do the acidification of the urine. They perform acidification of the urine by the tubules. Acidification of the urine by the tubules is the most important mechanism of acid-base balance physiology. The details of acidification, I would love you to refer to the nephrology physiology and connect the dots and learn more about the acidification defects of the tubules. But in this session, we are going to get an overview. The acid is secreted. The H plus secretion occurs in the form of ammonium ion. It is secreted in the form of ammonium ion. But this ammonium ion has to combine with the chloride ion. To be excreted as ammonium chloride. So if I want to assess the acidification function of the tubule, which are the two tests that I can do? If I want to measure the acidification function of the tubules, one, I can ask for the urine pH. So if I ask you What is normal urine pH? Because the acidification, acid that is generated in the cell is normally excreted into the kidney, the normal urine pH has to be slightly acidic. The normal urine pH has to be slightly acidic so that it can balance the equation in the blood and maintain the normal blood pH can be present. But the other test which I can do, I can measure the urinary H plus level. I want to see how much is the acid content in the urine. I can measure urinary H plus level. But unfortunately, urinary H plus measurement in the laboratory is not only expensive but also inaccurate, and that is why it is commercially not available. There is not a single commercial laboratory which will do this test for you. So what can I do? Instead of measuring the urinary H plus, what does it combine with? It combines with the chloride. So what I can say? The urinary H plus is directly proportional to the urine chloride levels. So it is the urine chloride level which act as the surrogate marker of acidification function. So I can say the urine chloride is an indirect marker of acidification by the tubules. Important terminology. Surrogate means what? Indirect marker. Ideally, I would like to measure urine H plus, but since I don't have a test available, I can also take the help of urine chloride level to identify the acidification function by the tubules. So we have got here the overview, the clinically relevant physiology of acid-base balance in the body. Now you can understand what can be the defects of acid-base balance in the body. So we can see here the primary defect of CO2 are respiratory disease. Defect of the kidney are called as the metabolic disease, where primary defect is in the bicarbonate. So let us head to the next level, that what are the acid-base balance defects that we want to know in clinical practice. Then we will come to the diagnosis on the ABG. The acid-base balance defects in practice can be classified into the four types. The acid-base defect in practice can be classified into the four types based on the pH. Make a small column for the pH, and based on the primary defect and based on the compensatory response. The primary defect and the compensatory response. Let us now switch from physiology to pathology. So like I told you, each topic we want to study in an integrated manner. So even though we are in the topic of ABG analysis, but to identify acid-base defect, we had to know the basic physiology. Then we have to know basic pathology, and then only we can understand assessment method, that is ABG analysis. So write down here, which are the four types of acid-base balance defect? We have got number 1, the metabolic acidosis. We have got the number 2, that is metabolic alkalosis. Metabolic acidosis, the metabolic alkalosis we have got here. Metabolic acidosis, metabolic alkalosis, along with the statistic also we want to keep adding. It is the metabolic alkalosis which is the most common defect in critical care among the ICU patient. Most common defect among the ICU patient is the metabolic alkalosis, though needless to say, Overall, if you see, most common is metabolic acidosis. Acidosis is the famous defect, but in the ICU, critically ill patient, the most common defect is metabolic alkalosis. The significance you will understand when we study about individual defect. The other two are the respiratory acidosis and the respiratory alkalosis. The respiratory acidosis give 2 lines and respiratory alkalosis also give 2 lines. The respiratory acidosis, respiratory alkalosis is the most common defect in the pregnancy. Most common defect in the pregnancy. The reason we have already understood in the previous video when we studied hyperventilation syndrome. What we said? In pregnancy, the elevated progesterone level stimulates the respiratory center. Pregnancy is also an emotional overload, right? So some element of anxiety is expected, leading to hyperventilation, making respiratory alkalosis most common acid-base balance defect during pregnancy. So as I told you, let us color code them now. When I say the primary defect is metabolic, it is a defect in the plasma bicarbonate level. But when I say that the primary defect is respiratory, it is the primary defect in the CO2 level in the plasma. Metabolic means disease of bicarbonate. Respiratory means primary defect of the carbon dioxide. We all know that acid alkali, bicarbonate is an alkali. So for acidosis to occur, the alkali has to decrease in the plasma. For alkalosis to occur, alkali has to increase in the plasma. But CO2 is the form of acid which is excreted by the lung. For acidosis means there is CO2 retention. CO2 retention, that is why we said it is same as hypoventilation disorders. While the respiratory alkalosis is a CO2 washout, that is why we said it is same as hyperventilation disorders. CO2 washout, that is hyperventilation disorder, we can say. So ABG can help identify the primary defect. After confirming primary defect, we also want to look at the compensatory response. In metabolic acidosis, what will be there? Respiratory compensation. The lung will try to reduce the levels of CO2. That means it will cause compensatory hyperventilation. There will be compensatory hyperventilation. While in alkalosis, the lung will try to retain the acid, retain the CO2. It will lead to hypoventilation, which we discussed will present as shallow breathing, which will present as only shallow breathing. In respiratory condition, kidney will try to compensate. The kidney will try to increase the alkali because of acidosis, and it will try to reduce the alkali in cases of alkalosis. It will try to reduce the alkali. So this is respiratory compensation. This is metabolic compensation, also called as renal compensation. So first we have enumerated which are the 4 acid-base balance defect along with their definition, that is primary defect, along with the compensatory responses. So now to diagnose the disease, the gold standard for diagnosis is the arterial blood gas analysis. The gold standard for diagnosis of acid-base defect is the arterial blood gas analysis. But before the interpretation, we must know few dictums in acid-base balance. Before we learn, go back to our ABG and learn the interpretation, we must know few dictums of acid-base balance physiology. Number one dictum, when you read the ABG for acid-base balance, we must know that the normal pH on the ABG does not exclude acid-base balance defect. Normal pH does not exclude acid-base balance defect. Does not exclude. How can we say pH normal must be normal? No, because it may be a compensated defect also. It may be a compensated defect also. So does not mean that the normal pH is totally normal. It may just be a case of compensated defect. That is rule number one. Making us understand that the combination of two or three defects, the combination of two or three defects are common in practice. When one is primary, the other compensatory is relatively common. So, two defects in the same ABG, very common. Having third defect also possible, but never all four. All four cannot occur together because I know two of the defect cannot occur in the same patient. I want you to think and tell me which two defects of acid-base balance cannot coexist in the same patient. So we obviously know that along with metabolic defect, respiratory can coexist. So the answer either has to be both metabolic cannot occur together or both respiratory cannot occur together. Which one would you like to choose? The answer? Yes, the answer is both respiratory disease. Why? Because look at the pathophysiology. Respiratory acidosis involves hypoventilation, while alkalosis involves hyperventilation. The respiratory apparatus is only one in one patient, no? So even Ramdev Baba cannot do both at the same time. Either you can do shallow breathing or rapid breathing. That means both these defects can never coexist in the same patient. So what you must write? Combination is common, but both the respiratory defects never coexist in the same time. At the same time, they can never occur together. That is dictum number 2. Dictum number 3 and 4 are regarding compensation, how it works in the body. That in a patient with primary metabolic defect, we must know that respiratory compensation, occurs within the minutes to hours, and hence some compensation, the change in the CO2, that is respiratory compensation, is always present at the time of diagnosis. It is always present at the time of diagnosis. So we can say that the CO2 value in a patient with metabolic defect cannot be taken as a normal reference range, because some compensation is bound to be there by the time they reach the hospital. So there's some change you have to prepare. You have to correct the CO2 range based on the primary metabolic defect. So what does the dictum say? In all patient with primary defect, you must calculate the expected CO2. You must calculate expected CO2 using the Winter's formula. You must calculate the expected CO2 using the Winter's formula. to differentiate between isolated metabolic defect, versus the mixed acid base balance defect. We will understand this more when we discuss the example on the next page. But right now, this much dictum let us know that metabolic disease means respiratory compensation always present because it occurs within minutes. Hence, it is always present at the time of diagnosis. So, in all patient with metabolic defect, you must calculate expected CO2. If the expected CO2 matches with the ABG report, that means the change is only compensation. The defect is only metabolic. But if the change in the CO2 is other than what is expected, that means there is an additional CO2 problem also. Metabolic is there, but there is additional respiratory problem also. So what we can say, that is called as mixed acid base balance defect. Number 4, in primary respiratory defect. In a primary respiratory defect, if you go to see the metabolic compensation, also known as the renal compensation, occurs over weeks and months. Doesn't occur immediately, occurs only over weeks and months, and hence the presence of compensation, that is change in the bicarbonate level. Change in the bicarbonate levels indicate compensation present. Indicates compensation present. If compensation is present, it indirectly tells you that it is indirectly going to tell that it is going to be a chronic disease. So the presence of compensation indicates chronic respiratory defect. Because if compensation is present, means at least weeks and months have gone through. That's why we want to know. So we have these dictums that we want to remember before we enter the ABG analysis. These are the dictums. So dictum number 1, we know to confirm acid base balance defect, we want to know arterial blood gas analysis. But know this fact that normal pH does not mean normal. Combination of 2 or 3 can occur, but both respiratory, never. In metabolic disease, some change in CO2 always present. So you calculate expected, know whether it is metabolic or mixed. In respiratory disease, metabolic compensation takes time. So if it is present, means it is a chronic respiratory defect. It indicates chronic respiratory defect when compensation is present. If it is not present, indirectly will mean that it is an acute respiratory defect. These are the points that you want to understand, dictums, before we go on to interpretation. So with this, we are completed the pathophysiology and the various physiological important points about acid base physiology. Now we can start with the stepwise interpretation of acid base balance in a valid ABG sample. The stepwise interpretation of acid base balance defect in a valid ABG sample. We can start. Right. So we can continue with the stepwise interpretation of ABG defects in a valid ABG. Now that we know the pathophysiology of acid base balance defect. If I take you back to the previous sessions, we have started with the ABG analysis and we have written it as step number 3. In the previous sessions, we have discussed the gas exchange defect and respiratory failure. In this session, we want to do assessment of acid-base balance defect on the ABG. Already we have written that we need the help of minimum two parameters. Essential is the pH, and along with pH, we need either the value of CO2 or bicarbonate value to confirm diagnosis of the defect. These are the four defects we want to see, the two respiratory and the two metabolic. Respiratory defect is primary defect of CO2. Metabolic defects are primary defect of bicarbonate, which we have already defined in this session. So we want to use the ABG to confirm the diagnosis of acid-base balance defect. So step number 1, what we do? We look at the pH. So based on the pH, we are going to first see. Based on the pH, we are going to classify the patient into two groups. What is single normal pH? 7.40. 7.40 is the single normal value for the pH. So when the pH in the given ABG is less than 7.40, we read it as the pH of the ABG is going down, indicating acidosis. When it is more than 7.40, we say the pH is going up, indicating alkalosis. The pH of the sample is going up, indicating alkalosis. That's the way to read. Once we know what is the defect, number 2, we want to know the primary defect, whether it is metabolic or respiratory, because we know that acidosis can be either metabolic or respiratory. So does the alkalosis. So for that, we want to look at, based on, we want to compare the direction of movement. We want to compare the direction of the pH movement. The direction of the pH movement with the direction of either the HCO3 or the CO2 movement. The HCO3 or the CO2 movement. So this comparison will help us identify what is the primary acid-base balance defect. It will help us identify what is the primary acid-base balance defect. It will help us identify. How? Let us see. So for example, if I see that the patient is having the direction of pH going down, that means patient is a case of acidosis. In a patient with acidosis, I have got two differentials. Either it can be a case of metabolic acidosis or respiratory acidosis. So when the pH is going down, I want to compare it with the direction of CO2 or the bicarbonate movement. So what I can say, when the direction of CO3 is the same as the pH, the primary defect is metabolic. The primary defect is metabolic when movement is on the same side. But when the movement is opposite to the pH, it indicates primary defect is respiratory. Indicates that primary defect is respiratory. So what we call this acronym? Acronym is called as ROMS. Respiratory movement is opposite, metabolic movement is same side. Respiratory movement is opposite direction, metabolic disease movement is in the same direction. This is the acronym we want to use. So we are wondering that how can we directly decide what is the defect? Well, this step is based on the definition we have written on the previous page. Take you back one page. On the previous page, we have enumerated the 4 types of acid-base balance defect along with their definition. What I want you to focus on is the empty column pH. In the example we just discussed, pH is going down, means patient is having acidosis. Two differentials are there. Acidosis can either be metabolic or respiratory. If you follow the chart, you will see that if the disease is metabolic, then the pH is going down, so is the bicarbonate, so is the CO2. All are going in the same direction. But in respiratory disease, pH is going down, but CO2 and bicarb both are moving upwards, opposite direction. So same side movement, metabolic, opposite side movement, respiratory disease. Can the formula work in alkalosis also? Yes, alkalosis also pH is going up. When along with pH, bicarbonate and CO2 also move in same direction, disease is metabolic. But pH is up, other two are going down, opposite direction, indicates respiratory disease. So based on the definition of acid-base balance defect, we have written down here what is the primary acid-base balance defect. So in the first two steps only, diagnosis is made, which is the problem. But which problem? Primary problem, already we know. But step number 3, what we want to know? We want to look at the presence of compensation. We want to look at the presence of compensation in this patient. Based on the presence of compensation, we can give further specificity to the diagnosis as discussed in dictum number 3 and dictum number 4. What we said? In metabolic disease, primary metabolic disease, some compensation is always present at the time of diagnosis. Some compensation is always present at the time of diagnosis. But in respiratory disease, the metabolic compensation takes time. So look at the bicarbonate value here. If the bicarbonate value remains normal or remains changed, abnormal. So bicarbonate is normal or bicarbonate value is abnormal. Two possibilities are there. If the bicarbonate value is abnormal, what did we say? Compensation is present. It indicates that compensation is present. When bicarbonate value is normal, it indicates there is no compensation. If no compensation is present, the defect is acute defect. The defect is acute defect because duration is small. But when the compensation is present, we have already written, it indicates chronic respiratory defect. When compensation is present, it indicates chronic respiratory defect, we can say. So based on dictum number 4, what we said? In primary respiratory disease, metabolic compensation occurs over weeks and months. So if compensation is present, the disease is chronic. Compensation is absent, means disease is acute. Diagnosis can be made based on the dictum number 4. Other side, example we are going to discuss, that in a metabolic disease, I told you that respiratory compensation occurs within minutes to hours. That means by the time patient comes to hospital, some compensation is always present. Let us take an example. When I say that the patient has come to you with a pH of 7.20 and bicarbonate value of 10 milliequivalent, what is your diagnosis here? In this patient, how you will read the ABG? You will say the pH is going downwards, suggestive of acidosis. And the bicarbonate 24 is normal, also going down in the same direction as the pH, indicating it is a primary metabolic acidosis. So one thing is for sure, that this patient is a case of primary metabolic acidosis. This defect is confirmed. But what MCQ wants to know? Whether the disease is only metabolic or whether it is a case of mixed acid-base balance disease. For that, what I want to do? First, I want to calculate expected CO2 in this case. I want to calculate expected CO2 in this case. Expected CO2 by Winter's formula 1.5 into patient's bicarb. The Winter's formula that we have written on previous page, 1.5 into patient's value of bicarbonate plus 8 plus minus 2. That is the reference range of expected CO2 in the above case, which is equal to 1.5 into 10, that is 15. 15 plus 8 is 23 plus minus 2. So 21 to 25 millimeter of mercury is the expected value in the above patient. So this is not normal, right? So normal value of CO2 is 35 to 45. That means what is there? This defect, the patient is having respiratory alkalosis. The patient is having respiratory alkalosis, definitely. But whether the respiratory alkalosis, if it is only this much, that means what? It is because of compensation. This is because of compensation due to primary defect, not due to separate disease. Separate disease, if it is there, then the ABG value will be different from the expected. So what we can say? Compare this expected CO2. You want to compare with the ABG value. You want to compare with the ABG value of CO2. ABG value of PaCO2, you want to compare the above expected CO2. If the ABG value is same as expected, if the ABG value is same as expected, that means the respiratory defect is only compensatory. There is only compensation. It is only a compensatory respiratory alkalosis. That means the patient is having isolated metabolic disease only. That means I can say that the patient is having isolated metabolic acidosis only. There is only one defect on the ABG. Other defect is there, but the other defect is not a real disease. It is only a compensatory respiratory alkalosis. So even though ABG has showing two problems, but actually there is only one problem, because whatever is the change in CO2 is as expected as a result of compensation. Clear here? It is as a result of compensation. So disease is only one. But if the ABG value of PaCO2 is different from the expected, it is different from the expected, whatever you are expecting 21 to 24, 25, but it is different from expected value. What does that tell me? It indicates the presence of, additional respiratory defect. That means there is something more. There is an additional respiratory defect along with the primary metabolic acidosis. That is there for sure. But metabolic acidosis is not alone. There is also additional respiratory defect. This is called as mixed acid-base balance defect. This is called as mixed acid-base balance defect. That's all. If you know the 3 steps of this ABG, you are done with ABG analysis on the arterial blood gas analysis. Very simple. If you get any question, first thing what you will do? Look at pH. After looking at pH, what will you compare it with? Direction of movement of the pH with either the bicarb or CO2. If movement is same, metabolic. Movement is opposite, defect is respiratory. In respiratory disease, only look at bicarb value. Bicarb value is 22 to 26, no? This is acute defect. But bicarb value is abnormal, this is chronic defect. In metabolic defect, always calculate expected CO2. If you get the value of the ABG of CO2 is same as expected, whatever is the defect is only compensatory. Problem is only metabolic. But when it is different from expected, that means there is, along with metabolic, there is additional respiratory defect also, indicating mixed acid base balance defect. Only these questions keep repeating, that in respiratory, acute, chronic, in metabolic, is it isolated or mixed? That's all we want to know. So ABG is the gold standard test for the diagnosis of the acid base balance defects. It is the gold standard for diagnosis of acid base balance defects, right? So in the next video, I am going to discuss the individual defects of acid base balance. So when we go back to assessment, what we also completed here, the third role of ABG. The role of ABG was also to detect the acid base balance disorders. This is how you use ABG to diagnose acid base balance disease. So put the whole session together. What we have understood today? We have understood that in a chronic condition, along with radiological test, you will ask for pulmonary function test, which will help identify mechanism of lung disease. But in emergency, along with radiology, I will do ABG analysis, which will tell me gas exchange defect, type of respiratory failure, also detect acid base balance defect. So one by one, we took care of each one of the problem. So in the next session, I am going to discuss individual acid base balance defect. In first video, we will be discussing both respiratory defects together. In the subsequent video, we will discuss metabolic acidosis, metabolic alkalosis together in the video, right? So two more videos for acid base balance defect. In each one of the defect, what we want to know? Same thing. We want to start with definition and reach till treatment and prognosis of each one of the metabolic defects, acid base defect, and that will complete the assessment methods in respiratory system disorder, right? So if I take you further back where we really started today, we started with approach to medicine, that in each one of the disease, what we have started, we have understood the physiology of respiratory system. We know what are the symptoms, how to approach the symptom, which are assessment method, and how to interpret the findings in assessment method. So after completing the videos on acid base defect, you can proceed to the classification video of respiratory defect and then go on to the individual disorders of respiratory system. Over to you. Acid base balance defects. One by one, let's go on.